Welcome to Living Chassidus. Together, let's live the Chassidus we learn. Welcome, everybody, to our Living Chassidus Life Skills series. I want to just make sure that we are, I'm going to set this one. Okay. So, here is how it works. Living Chassidus is an organization based here in Crown Heights, but as you guys all can tell, all of our programs, basically 99% of our programs are in person and also on Zoom. So even if something is in person, you can always join on Zoom as well. So feel free to send our flyers to anyone, anywhere, all over the country or even out of the country. Living Chassidus's goal is to care for single and newly married women, although some of our programs are open to all women. And recently we actually had 2 programs that were open to everybody. So today's event is more geared towards women. If anybody saw the topic, I'm sure you can realize why. And we have a lot of different types of classes and a lot of different types of support. So Living Chassidus is based off of 3 things: learning, community, and support. So right now we are doing our learning. We also do programs that build community and they build that camaraderie, friendship, that type of relationship so that everybody can be together with each other. And we also provide all kinds of support. So many of you know, we recently celebrated a Living Chassidus member's son's bris, and we also celebrated some l'chaim, lots of l'chaims and lots of weddings and lots of babies and lots of amazing news. And we're also provide support if chas v'shalom everything is not so amazing. So we are here and we are happy to help. Tonight, though, we are focusing on what we call the Life Skills series. So our goal within the Life Skills series is that by the time that you reach certain times of your life, whether it's getting married or whether it's, tonight's topic is not necessarily for marriage in particular, but the idea is that you shouldn't get to that point and say, I wish somebody would have told me. Here at Living Chassidus, we are trying our best to do just that. We want to tell you. And so here we are discussing a very, very important topic. A few years ago, someone reached out to me, and I want to give an anonymous shout out to her for being brave and reaching out and saying, hey, you know what? I wish more people would have knowledge about general feminine health. And it's been something that I've been thinking about, and I've been working through how do we do this and who's the best person for it. And right away, my mindset went to Judy. So I want to introduce tonight's speaker. And I apologize, I want to jump before that. I want to share that tonight's event is sponsored in honor of our Leulei Nishmas for Chai Rivka Bas Arya Leib. So a very, very huge shout out and a thank you for the sponsorship to Bracha Zirkin and her family. And may Chai Rivka Bas Arya Leib, Allah v'shalom, she should have an aliyas and neshama. And tonight, all of our learning, and every time anybody listens to this recording, she should get an aliyas and neshama. So back to our speaker. I'll give you the official introduction first, and then I'll give you my personal introduction. So official introduction is Judy Ribner is a midwife doctor currently practicing holistic women's healthcare in New York City. She earned her graduate degree in midwifery from Downstate Medical Center and her doctorate. Let me repeat that. Her doctorate. A DNP from NYU, graduating as a valedictorian of NYU. So kol hakavod, a huge, huge shout out and round of applause to Judy. So that is amazing. Judy is dedicated to helping people help themselves. Judy's passion is to help share current, evidence-based, accurate information and research so that people can be empowered to make informed healthcare choices. Judy Ribner has also joined Living Chassidus for several other talks, and you can definitely go check them out on our YouTube channel or any of our podcasts. And she also has her own level of following. So you can always search Judy Ribner and hear tons of amazing things. And my last little piece is that she is one of my best friends, and I have the great, great solace of having her in my life. And I'm so, so lucky that she's here and that she's joining us. So thank you so much, Judy. Mike's off to you.
Hi, Michal. Do you hear me? Am I unclear? Hi,
You're
Michal.
great. I hear you.
Yeah, okay. So firstly, I'm so humbled by the fact that you considered me one of your best friends, because I want to say, like, I cherish our friendship, and I'm humbled to make it to that list of your friends and a close friend and a trusted friend. Something you mentioned really resonates with me just as a human being. You said you don't want people to say, I wish I would have known. I can't even tell you how many times I've sat in consultations and met with new families who were joining our practice to home birth or coming for something else. And they said, I just never knew, or I wish someone would have just told this to us earlier. The knowledge that you have and the insight that you have and the perspective and the intuition can literally save so much human suffering. And I want to say that if I in any which way can be helpful during this discussion to empower people to make informed decisions, then this entire discussion then was worth it. Because what you know, Michal, and what you share and what you stand for and what you represent really has the power to change people's lives. And kol hakavod to you. And I personally wish I knew more when I had gotten married or when I was a young adult. There are decisions that I've made that I never made from an informed place. So I really wish I was under your influence, over 10 years ago, Michal. So, so here I am. It's been a long journey. I want to share a little bit about my background. I was born to an unmedicated mother. My mother birthed me with mamaz. My mother exclusively breastfed me. My mother was natural minded. And back then that was progressive, today. And she's taught me to think rather than just to trust. So that's my comfort zone. And I like having information. I don't like outsourcing my thinking to other people, certainly not to authoritarian people. I like to be involved in the process. So in the last 10 years, I spent many years in school, and I very humbly, as Michal had mentioned, I was a valedictorian of NYU, and I did it not because I have any ego. I have absolutely no emotional need to have it. I did it for one purpose. I did it to lend credibility to a perspective that is not a common perspective in this part of the world. That was my motivation. So I'm coming from a place that sees the medical establishment as having saved people's lives. I see the mainstream medical establishment as having been a blessing to this planet because of its advances and because of its extraordinary capabilities. But I also see Western medicine as being so powerful that if it can save a person's life, it can also cause trouble. And therefore, Western medicine should be used appropriately, and medical care should be gotten from a skilled person in a thought out way, and in a way that's current, that's not outdated. And a lot of what we're going to discuss today are mainstream medical recommendations. They're not midwifery recommendations. They're not natural minded. They're not holistic. And I'm going to quote to you the professional organizations that back what we're discussing. And the purpose of why I'm doing that is that I want you to have the opportunity that I always like to have. I don't like to need a trust. I like to have the information. So I'm going to share with you where you can retrieve that information. So you can read up on it yourself. And this way you can be an informed healthcare consumer, which is so important. And the topic for tonight is completely Michal's credit. I never could have thought of it, but it's a great topic. It's relevant, I think, to everybody who's female. And it's courageous, this topic, because to talk about GYN care and to talk about GYN exams and to talk about such a private, charged part of the body where people also have histories with, right? Sexual relationships they've been involved with, or histories, God forbid, of abuse, or feeling of inadequacy, potentially with body image, right? It's an emotionally charged body type, hopefully in a positive way, but not always is it. And either way, it's a reserved, culturally, we consider it incredibly private. And therefore, decisions regarding whether to go for a pap smear, is it really necessary? Is it beneficial? Is it going to improve my health? Those decisions are important decisions because we're not talking about swabbing people's ears or swabbing people's noses, right? These are really sacred parts of the body. Every part of the body is sacred, but especially such a private part of the body. So let's just jump right in. And the first discussion we can have is firstly about hygiene. And I would really recommend just coming from the perspective that the vaginal canal and the perineum, they have what's called a microbiome. They have many bacteria, good bacteria, that help keep bad bacteria and the overgrowth of yeast in check. So people often have the question, like, how thoroughly should I wash myself vaginally? The answer is not very thoroughly, meaning not internally. Better not to cleanse the inside of the vagina thoroughly. And they sell all sorts of products on the market where people can put like an applicator full of water. It's not what the body benefits from. And the reason is straightforward. When we wash that area vigorously, we rinse out good bacteria. So we make ourselves susceptible and at risk for the overgrowth of bad bacteria or the overgrowth of yeast. So just off the bat, when we're cleansing, it should be externally, and it should not be with strong soaps. It should be rather with water and enough to be clean. Of course, we're encouraging cleanliness, but not over cleanliness, like to the point of using fragrances and other artificial chemicals that can be irritants to that part of the body. Even when using a lubricant for whatever reason, even then a conscious choice of lubricant is important, right? Do you want to put something in your body there that you wouldn't put in your mouth? If you can't read or pronounce the ingredients, you probably don't want it inside your vagina, the same way you wouldn't want to swallow it. So olive oil would be a recommended lubricant. Avocado oil is a recommended lubricant, potentially coconut oil. So that's just briefly about hygiene. But the bigger discussion here is pap smears, pelvic exams, breast exams. I mean, that's a lot of checking. That's a lot of exposure to another person, even if they're a professional. And I'm going to say that professionals do typically have a different relationship with the human body. And there is a certain detachment, like it doesn't hit them the same way when they check somebody, it doesn't hit them the same way that maybe a person who's never checked somebody would register it. So in that regard, it's a good choice that, you know, you're using somebody that you're not their first pelvic exam, you're not their first breast exam. But are these exams really recommended or are they not? So for years in the United States, every year, every woman was encouraged to get a pelvic exam. And that meant that there was a professional putting inside 2 fingers into that woman's vagina. That means there was a professional putting inside potentially a speculum or doing a rectal exam. Like these are invasive. These are invasive exams. And luckily, those exams have fallen out of favor for women who don't have any specific complaints or symptoms, who are non-pregnant. And the reason those exams have fallen out of favor, and let's say, for example, the American Academy of Family Physicians, they specifically, that's a mainstream medical professional organization that sets professional standards and recommendations for family doctors, right? This is not midwifery, this is not natural minded, this is not holistic, this is just mainstream medical care in the United States. They specifically recommend against doing those exams. And I'm quite relieved to hear that. And they say that there's an increase in risk of people having further invasive testing if they have such an exam and undergoing unnecessary treatment, that the benefits of those exams do not outweigh the risks. So they should not be done routinely for a person who doesn't have any symptoms and any complaints, and there's nothing specific to check. I was just at a birth yesterday. It was not my client, which is a unique situation for me. Usually by the time I go to a birth, I know a mother really well and I'm really connected to her. And we spent a lot of time during the pregnancy. I got a call yesterday morning at 7:30 in the morning from another New York City home birth midwife who was really in a pinch. She had a personal situation going on in her life and she was not able to attend her client's birth. So she called me up and she asked me, would I go? And I said, of course, absolutely. And I got dressed and I took my birth equipment and I jumped in my car. And an hour later, I was at the door. And before I walked into the house, my first moment was just, it hit me that I'm walking into a birth. And as I was driving, I called the midwife just to get like a brief history, the clinical piece and just to hear her, description of her client as a human being so that I can try to help this mother have the experience that she's seeking to have. But before I walked in and my birth assistant met me at the door, I was like, wow, I'm about to be at the center of a human being's most critical life event. And I have never met her and she has never met me. And that was a sad moment for me, that this mother is birthing with a person who she has never met before. And thank God she had the most beautiful birth and she had an intact perineum. And I did whatever she wanted me to do. And her voice was the lead voice and the only voice. And she birthed on her own terms and she birthed peacefully and with dignity and gently. And she had uninterrupted skin-to-skin contact for however long she wanted it. And we waited quite an amount of time before we clamped and cut the cord. It was like everything. I asked permission. I completely negated myself. I practiced in a way that she wanted me to do things that were more interventive than what I would typically do. And I totally respected her choice. And I shed myself. It wasn't about me. It was all about her. But in that moment, when I was thinking that I'm entering the birthing space of a woman that I never met before, I also realized birth is so private. Just the fact that I, who she doesn't know, should see her exposed is such a vulnerable moment. And the appreciation for how vulnerable a pelvic exam can make a person feel is so important. If there's no clinical benefit to it, and if it's controversial, whether having that exam is even going to help the person, that's a big 1 minute. Should we be doing this? Why would it be that checking more doesn't lead to better things? And that's the concept of overscreening. Overscreening means that when you look at a large sample of people, and we're talking tens of thousands of people, or possibly even hundreds of thousands of people, it means if you check them and they don't have better outcomes, or you do cancer screenings and they overall don't have better outcomes, then a huge sample of people, a statistically significant sample of people who didn't have that testing, and all you find is that the people who had testing ended up having more biopsies, more invasive tests, more treatment, but they're not living longer and they don't have better quality of life and they don't have fewer diseases, then is there benefit to that testing? No, that's what overscreening means. A screening test that doesn't yield benefit on a population level. It only yields more diagnoses and more treatment, but it doesn't yield better outcomes. And that's not to say that there isn't one person who may have benefited from being tested and, oh, wow, they caught something that they wouldn't have caught and it was truly necessary to catch it. We're talking on a population level. We're not talking on an individual level. Okay, so we already clarified that the pelvic exam is controversial at best. There are some professional organizations that say you can offer it, but it should be shared decision making. The woman should be informed that it may have risks and may not have any benefit. So there's a controversy in whether it's really not recommended, like not to do it, or it's just unknown whether it's beneficial or not. But let's move on, because we have quite an agenda that Michal prepared for us, and I love it and I want to accomplish it. Let's move on to what if somebody is having a pelvic exam? They've made the decision, they feel safer with being checked, or they have a specific symptom that they want checked. There is time and place for pelvic exams, right? How should a pelvic exam be done that it's empowering, that it's dignified, that it's a learning opportunity, that a woman feels that she walks away intact in every regard? And the way I was trained, and this was just in SUNY Downstate's midwifery program, is one, to always offer a woman a mirror. Let her have the option to look along with her midwife or her provider, whoever is doing that exam. That's her opportunity to learn about her own body. That's her opportunity that she can ask questions. That's her opportunity that she can say, what is that? Or I was always curious about this. Another thing I was taught to do is to always articulate before starting an exam. At any point you want me to stop, just say so, and I'll stop right away. That centers control to people to know they are completely 100% in charge of anything happening to their body. And the minute they withdraw consent and don't want it done, I will absolutely listen that second. It should be self-understood that that would be the case. And I hope it is self-understood, but articulating it gives people that additional level of control. When I was training to become a midwife, and we did this quite a number of years ago already, we did what's called peer pelvic exams. And please don't cringe, and I'll share with you what that means. A peer pelvic exam means it was voluntary. You didn't have to do it. But if you wanted to, you could sign up. And one midwifery student did a pelvic exam on another midwifery student in a private place. And there was a professor who was supervising what was happening and guiding the exam. And one of the reasons that midwifery education values peer pelvic exams is that it teaches midwives how to do a pelvic exam in a way that equalizes the relationship. It teaches midwives how to do a pelvic exam in a way that they themselves would want to have a pelvic exam done. Another thing I was taught when doing a pelvic exam, which I think is important, is firstly to get very clear consent, not implied consent, right? If someone's undressed and like there, that's implied consent. No, to really ask for explicit permission. Another thing that I was taught, and I want to share it with everybody because I want people to know that they deserve this kind of care, and that this care, there are many professionals who were taught to give care this way. You can find care, this kind of care, is to do what's called anticipatory guidance. And that's a fancy way of describing that you discuss with the person in advance what's going to be done as you're asking permission, so that they know what to expect. And of course, you say, if you don't want, we won't do it. But at least there's no surprises. And so much so that even if you're putting in a speculum and that speculum makes a clicking sound, the speculum is that plastic or metal device that has two bills this size sticking out of it that go inside vaginally, that get opened so that a person's cervix can be visualized and the provider can see it. And by the way, if you're looking at your own, you could see your own cervix with a mirror. We just placed an IUD for a woman, and a person can see their own cervix, just so you should know that, which is incredible. But like if a speculum is in, it's not just a provider can see it, the person herself can see it. But we were taught to say there's going to be a clicking sound. We were taught to say, so that even that doesn't surprise a person, we were taught that before putting our fingers inside a woman vaginally, to first touch the inner thigh with our outer hand and say, this is my hand. And then when we put two fingers inside, to say, these are my fingers, so that the woman knows that you're about to enter her body, that she has that anticipation in place. You know, I've witnessed an outstanding midwife do a pelvic exam on somebody. And what I remember thinking is that the level of concern that she had for modesty, to keep that woman's body as covered as possible, besides for what needed to be exposed, the level that she centered control to the woman she was doing the pelvic exam on, the level that she had that woman participate in her own care, made me realize that a pelvic exam doesn't have to be something dreadful, but it really can be an opportunity. Now, in no way am I encouraging that people should have pelvic exams that don't have clinical benefit to them. But if a person is having one, they can know that they can get good care. I'll tell you the truth, I don't really check people so often. Like in our practice, I'm a private person. I'm not looking to, I'm looking to respect people's privacy within the context of clinical safety, right? So, and I practice with the appreciation that it's such an incredibly reserved part of the body. So, I mean, we've had mothers in our practice that I haven't checked, I haven't really seen besides for at the birth itself, right? Like I wasn't really doing a vaginal exam during the labor. I wasn't, if there was no clinical benefit and if the mother didn't ask for one, I wasn't checking her during the pregnancy when there was no clinical benefit or the mother wasn't specifically asking for it, which is most of our pregnancies. And people should know that even if you have a baby, you can get private kind of care, and that's an option out there. But I do want to mention that there are practices in New York City that offer home visits for GYN care. And there are practices in New York City, home birth practices, that even offer fertility care at home. So people have the opportunity to have that experience centered in their own environment, which may add a level of comfort and safety and reassurance and privacy. That's another option. Let's talk about breast exams. I mean, people tell me that in a lot of mikvahos, like at the mikvah, there are these signs up at the shower teaching women how to perform a thorough and proper self-breast exam. A self-breast exam has been like indoctrinated in the United States into women's minds. Like this is a way that's going to save them from cancer, right? Because by doing a self-breast exam, you're going to be able to catch cancer early at a point that it's not deadly, get the treatment right away. And like self-breast exams are the ticket to good breast health. The latest recommendation is by the American Cancer Society is that an average risk woman should not perform a self-breast exam. So if you see a sign up recommending it universally to women, that's outdated, just so you should know, by the American Cancer Society's guidelines. Instead, something called self-breast awareness is the newer recommendation, which just means people should be aware of what their body looks like, what their typical breast tissue looks like, so that if they detect a change or they have a concern, and they should know the signs and symptoms of a concern, like a dimple, if that's potentially a concern, or very red scaly skin is potentially a concern, or skin that looks like an orange peel, very rare, but that could be quite concerning. Discharge coming out of the nipple that isn't expected, and especially when it's not the same on either side, or if the nipple is pulled in. Some of these can be harmless, but these are all things that potentially a person can have checked out and should maybe have checked out. And when I say discharge, I mean it doesn't look like pale yellow, and like a mother who just finished breastfeeding can have discharge on both sides for quite a few months, right? Or sometimes hormonally during the month, people have a little bit of discharge on both sides. That's normal. We're talking something that's unusual. So self-breast awareness is important, that not to ignore something that can be troublesome, but to go ahead and take the hand and do in a circular motion the way the previous generation of women has been taught to do. That's not recommended for an average risk woman. And the reason is straightforward. It's the same idea of an unnecessary pelvic exam. Self-breast exams have not been shown to improve clinical outcomes across large populations of women. What it did is that it prompted women to go for further testing because they became alarmed, and then to undergo biopsies or treatments that were unnecessary and did not help their health. So a self-breast exam can be more harmful potentially than beneficial for an average risk woman. Even a clinical breast exam, even having a provider, a doctor or midwife or nurse practitioner, even having a professional do a breast exam, even that's controversial in today's day. Some professional guidelines still recommend it or say it can be offered, but the American Cancer Society, I want to read it to you straight from the American Cancer Society. And again, this is totally available. If you Google it, you don't have to have membership with the organization, and nobody has to trust me. It's available to you. I printed it out in advance of this discussion. Research has not shown a clear benefit of regular physical breast exams done by either a health professional, what's called a clinical breast exam, or by women themselves, breast self-exams. Women should be familiar with how their breasts normally look and feel and should report any changes to a healthcare provider right away. So as we described, if there's something unusual, report it. They're also saying that this does not mean that these exams should never be done. In some situations, particularly for women at higher than average risk, for example, healthcare providers may still offer clinical breast exams. So we're talking about average risk women. They're saying that there's just no clear benefit to it. So they should not be done. Okay. Let's move on to pap smears, because that also is like, I mean, I hear these things and I'm telling you, it's long outdated. There is no professional organization recommending it. Annual pap smear in today's day, nobody recommends that. Are there old school practices still offering it? Yeah, but that doesn't mean it's evidence-based. That doesn't mean it improves people's health. Quite the contrary. You know, and I think one of the important parts of getting care is to get current care, as we described, that updates in modern medicine should be integrated into clinical practice, right? Let's say I was trained in the 1990s. Does it mean that in 2022, I should be practicing 1990s midwifery care or medical care? Of course not, right? Part of the responsibility of being a good provider is to read and stay current. So if you hear of somebody offering an annual pap smear, that's a red flag. People who have normal pap results, and of course, if someone had concerning results, that's a different discussion. But for somebody, sure, I love that question, a pap smear. A pap smear is a routine part of women's health care. And what's invasive in terms of privacy-wise, it means going all the way inside the woman's vagina and scraping off some of the cells with a brush on her cervix, right? A woman's vagina is the part of her body, the orifice that's between the urethra and the anus, right? A woman urinates from her urethra, she defecates from her anus, and in between those two places is her vagina. That's where she gets her period from. That's where she bleeds from monthly, right? And that's where a baby is born from. That's where a woman has relations. So if a woman puts her finger all the way inside her vagina, and somebody who's a virgin should be able to get one finger in, they won't be able to get in two fingers necessarily easily, but one finger they should be able to get in with relative ease. If a person puts their finger all the way inside, they're going to hit something that feels like the tip of their nose. And that hard piece that's like sticking out, that's the woman's cervix. It's about 1 to 3 centimeters long. And depending on what time of the month it is for her, like if she's ovulating or if she's not middle of the month, but if she's like just after her period, it will either be softer or harder. So the cervix can change its consistency, how it feels like. And the cervix can also even shift its position a little bit. But that cervix is the bottommost part of the uterus. And it's this little thing that's what dilates to fully dilated when a baby's coming out. And above the cervix is the uterus. And in the uterus is where a baby grows. In the uterus is where the lining thickens every month and before a period, and it gets shed and released during a period. But that cervix is in a pap smear is scraped, not roughly, gently, and those cells that come off are sent off to a lab to check if there's like a likelihood that this person is going to develop cervical cancer in the next few years. And cervical cancer is a slow growing cancer. It doesn't, it takes time to evolve. But so pap smears have been done routinely on women in the United States every single year. And people were basically told that if you don't come for an annual pap smear, you can potentially be growing some sort of cancer that we could catch early on that we would be missing if you don't come for a pap smear. And guidelines have completely moved away from that. And the reason is straightforward. Doing an annual pap smear on healthy women who had normal pap results the year before led to more diagnosis of, oh, this looks problematic, more treatments like, oh, let's test this, let's biopsy it, let's treat it. And there were no better outcomes to show for it. So it caused more harm than good. The World Health Organization, which is like the global professional organization that sets recommendations across the world, they say that a pap smear should be done starting from age 30 and done every 5 to 10 years. That's the most non-frequent recommendation that I know of, just so you should know. American guidelines are also split. Different organizations have different recommendations, but nobody recommends that it be done before the age of 21 routinely. Nobody, no professional organization. And I'll just share with you what the American Cancer Society says. They say people should start getting a pap smear from the age of 25 to 65, and that they should have it every 5 years, ideally no pap smear actually, but that they should only be tested for something called HPV. HPV is the virus that they have found that has led ultimately to cervical cancer. So if a person tests negative with HPV, there is no reason to be doing a pap smear by mainstream guidelines nowadays. And you don't either have to scrape the cervix anymore. You just have to test vaginally, swab it, because the HPV virus is inside the vagina there. Actually, you can even do a self-collected HPV test, which means it's preferable not to get a pap smear nowadays, according to the World Health Organization, according to the American Cancer Society. It's preferable instead to just get the HPV testing done, and people can test themselves for HPV with very good accuracy. So just so you know that. I personally don't know of the self-collection kits. I'm sure they exist. I think they're used more in rural areas in the United States where people don't have easy access to coming into an office. So those kits are mailed out to people, but it can be tested by yourself, just so you know that. So we recently had somebody who we thought was going to want a pap smear, and we were going to offer her that she can just self-collect it. We're not doing a pap smear, we're just doing HPV testing, and we were going to offer her to self-collect it. In the end, she declined it, but we were going to offer to her that she can just self-collect it, and we were going to send it off to the lab. But every 5 years, starting from the age of 25 through the age of 65, they recommend that once a person turns 65, if they've had the last few tests were normal, they should not go for further testing beyond the age of 65. So that's for pap smears. If anybody mentions that to you, that, oh, it's recommended. What's HPV testing? HPV testing, excellent question. HPV testing is what's recommended now in place of a pap smear. The pap smear was implemented as a way to screen for cancer of the cervix, but HPV testing for that HPV virus is considered a better way to screen for the potential for cervical cancer than doing a pap smear. So HPV is like the new pap smear. It's like the better way to go for a pap smear is to just get HPV testing alone without any pap smear. Okay, so let's move on. We've discussed hygiene. We've discussed pelvic exams, that if you don't have any symptoms, non-pregnant woman, if you don't have any specific issues or concerns, it's more than reasonable to not have a pelvic exam. And some professional organizations recommend that you should not have a pelvic exam. By the way, you do not need to have a pelvic exam in order to get hormonal contraception. or any of the contraceptions other than the ones that specifically go inside, for example, like the copper IUD or the hormonal IUD. But if somebody wanted to get birth control pills, they do not need to have a pelvic exam for that, just so you know that. And we discussed pelvic exams. We discussed pap smears like cervical cancer screenings, and we discussed breast exams. That's pretty much for a woman under the age of 50. That's pretty much the routine screening that have been done on women in this country up until now. So that pretty much covers it. Mammograms are a much more involved discussion. It used to be at the age of 40, an average risk woman should just go every year. Now there are professional organizations that do not agree with that recommendation. The United States Preventive Task Force says actually that an average risk woman can start a mammogram at the age of 50 and go every second year. So that's quite a difference than starting every 40. And mammogram is a much more involved. It's a low dose X-ray that's applied to the breast tissue as a screening test for breast cancer, but it is not a harmless test. You're literally directing X-ray radiation at the breast tissue as the breast tissue is being compressed. So a small percentage of breast cancers are actually caused by mammograms, by the very screening tool that was designed to prevent breast cancer, right? I mean, to identify breast cancer and to treat it. So there are alternatives to that, like thermography, and that's way beyond our discussion tonight, because thermography is not supported by some of the mainstream medical professional organizations. So it's a very involved discussion, but I do want people to know that there's a lot to talk about mammograms as well. Let's talk for a minute about hormonal contraception and non-hormonal contraception and the concept of birth control. And when touching the cord to your headphones, it makes a loud sound. Heads up. Thank you so much. Is it better if I talk without headphones? Because if it's clear that I talk without headphones, I'll happily take my headphones off. Contraception is such a courageous topic to talk about. And having babies is a very strong value in our religious group. And it's a discussion that very much crosses beyond healthcare. It's a discussion that involves religion. It's a discussion that involves relationships. It's a discussion that involves emotional health. It's a discussion that involves self-care. There's so many factors that influence people's decisions on whether to use a product that will prevent their ability or reduce their likelihood to becoming pregnant. That's what contraception is. There are many ways to prevent pregnancy, not one of which is foolproof. Even sterilization has some level of risk, has a failure rate, just so you should know that. Even people who surgically go to the ends of the world to stop their ability to get pregnant, sterilization, even that can fail, which is, of course, eye-opening that there's just so much human control that we have over the process, which is humbling. But I want to make a very clear disclaimer that the perspective I'm sharing right now is only the healthcare perspective, meaning the risks, benefits to contraception, the different forms of contraception, the level of effectiveness to each form of contraception, how to access it, like can you buy it over the counter in a pharmacy or do you need a provider to prescribe it? This is a very narrow perspective because it's only the healthcare perspective. I don't have any qualifications or expertise to discuss the religious component. So it's something that should be potentially discussed with a person like Posig or Dayan or Rav or a religious authority. I don't want to in any which way trespass into that. And I don't want to in any which way make a recommendation that contradicts somebody's religious beliefs. So I am here to say that I am sharing strictly the healthcare perspective. Even that, I'm sure there's even more out there than what I'm sharing. And firstly, for the purposes of time, we're gonna limit how much time we spend on each one. Each one can really probably deserve an hour in and of itself. But at least this will just be like the menu of options in brief so that people have what to go and research, right? Going back for thousands of years, women in, thank you, ask a rub. Okay, excellent, right. This is like, I don't want to take any religious responsibility. I take only responsibility for whether I'm accurate in terms of telling you if the method is effective or not, and what the risks are, the benefits. That's the only responsibility I take. Everything else, please direct to a religious authority. All other questions. Whether you can use it, what method to use, all of that, outside of, all religious, all to the religious authority. For thousands of years, our society, when they had a baby, a woman had a baby, she typically did not have the ability to get pregnant for at least 2 years afterward as she was breastfeeding her baby. And that was the natural form of contraception for generations. So our species did not procreate and reproduce every year. It's that there was a natural break between babies and between pregnancies that the body had built in for itself. In today's day, relying on breastfeeding for contraception, we're going to discuss what the benefit risk is, but many women will ovulate and will have the ability to get pregnant even when they are breastfeeding. And that may be because there's artificial lighting. And we don't live in alignment with the planet the way we used to be. Our bodies are not in sync with the moon cycles the way women's bodies used to be. And that may also be why we don't nurse clean, as it's called, which means to nurse without ovulating, to not ovulate and not have the ability to get pregnant when nursing. That may also be because of hormones in chickens and commercialized food that we eat. So it's multifactorial why in our industrialized society, many women cannot rely on breastfeeding in order to prevent pregnancy. So it's like the fact that we really need that something to prevent pregnancy after a baby is almost like a form of our unnatural, is almost a consequence of our unnatural world. Now, there are people who also take a break or don't have children for other reasons, like medical reasons, not just because they just had a baby. There are people who don't have children right away when they get married for other reasons. And again, ask a Rav, because it's a religious matter, but there are many reasons why people don't want to become pregnant. And there are many options for them if they don't want to become pregnant. There's a group of options that all use synthetic hormones. And those synthetic hormones are stopping the body's ability to become pregnant through different effects on a woman's reproductive system, either by stopping her from ovulating or from changing the cervical mucus in her body. And that entire group of hormonal contraception has a number of different ways that you can give those hormones to a person's body, but those all use hormones. And I want to list them out quickly. One is the Nuva ring, which is a ring that goes inside vaginally. Another is a patch where people can put on their skin, a patch that gives them hormones into their bloodstream on a daily basis. That's a form of another hormonal form of contraception. There's a pill. That's hormonal form of contraception. There are different kinds of pills with different doses of hormones and different combinations of hormones. So the birth control pill is not one type of pill. There are many types of pills available in the United States today, but they're all use synthetic hormones. Another type of hormonal form of contraception is a hormonal IUD, and that's a little T-shaped device that gets inserted by a healthcare provider inside the woman's uterus. A hormonal or IUD uses hormones. I'm trying to think if I missed any, as I'm just going to look through my notes for a second, so I'll make sure that I don't miss anything. I think, oh, there's another one. There's a shot. This is very rare. I don't see people, at least in the circle that I work with, I don't really see this being used commonly. There's an injection of hormones that a person can get every few months to prevent pregnancy. There's an implant also, not a common choice in the circles that I work with and clientele that I work with, that goes into the arm, like over here, and it goes just underneath the skin. And it's a very effective form of contraception, but that's also, it gives the body off hormones. So there's a whole nother group of contraception that does not involve giving your body any synthetic chemicals, that does not involve giving your body a medication that disrupts the body's own ability to synthesize estrogen and progesterone and these reproductive hormones. So there's definitely a time and place for synthetic hormones, and I'm grateful that those products exist on the market. But in the circle that I tend to work with, women are cautious that they don't want to take synthetic hormones, either because of previous experiences with it, like breast tenderness or mood changes or acne or weight gain or low sexual desire. They felt that they were in some way impacted by the birth control, by the synthetic hormone, in ways that they didn't like it, like they had side effects from it or nausea. So some people don't want synthetic hormones because they've tried it and it hasn't worked for them. Some people don't want synthetic hormones because they're concerned about their potential risks on breast cancer. They don't want to take any, if there's a possibility that there's an increased risk of breast cancer from being on synthetic hormone, they don't want to take any of those chances. Some people don't want to be on synthetic hormones because they're concerned about the side effects it will have on their microbiome, which means the good bacteria in their gut, which regulates their immune system, which regulates their metabolism. Some people say, I've done really well on hormonal contraception. I love it. And they keep using it and they do really well with it. So there's all types of people and all types of choices, and all those choices are supported. Now, there are some people who take hormonal contraception, but not because they want the contraceptive benefit, not because they're trying to prevent pregnancy, but because they're trying to get other effects from those pills on their body for other reasons, like they have endometriosis or they have PCOS. Not that those are the only treatments for those conditions, but they have other reasons why they take those hormones. So there's a wide range of people's goals when they choose hormonal contraception. Some people take hormonal contraception as their form of birth control because nobody ever told them that there's another option. And I've met such people. So, right, if they had a 10-minute visit with their provider, and in that 10-minute visit, they had to have a physical exam and get the prescription and get the instructions on how to take the birth control, there was not really much time to discuss what the other available possibilities are, right? Not everybody can get hormonal contraception. Like if a person has an increased risk of breast cancer, then they're not recommended to take certain forms of birth control. If a person has a risk to have a blood clot, and their risk is high enough that they would get a blood clot, they're not supposed to take certain kinds of hormonal contraception. Some they can, some they can't. So depending on which hormonal contraception, is it the pill? Which pill? Is it the hormonal IUD? Is it the implant? Depending on what the person's medical history is, that sometimes limits what options are available to the person, just so you should know that. And a competent provider, before he or she prescribes or implants or places the contraception, will take a thorough history so that they know whether or not this form is suitable for this particular person, right? But let's talk about the non-hormonal forms of contraception, because those are less talked about, but they definitely exist. One is a copper IUD, and that's the most effective form of contraception that's non-hormonal other than sterilization. Sterilization means surgically cutting a person's tubes, and I think that that's religiously incredibly controversial, just so you should know that, incredibly so, and I'm not competent to have an opinion on that, but I want to mention that. Every form of contraception, almost every form of contraception, besides for a couple of them, I've encountered people who told me that their Rav was not okay with it. So I also want to mention that just because someone tells you that they're using it, it doesn't mean that you're going to feel religiously comfortable to use it. And it depends on who you ask, and who your Rav and who your posek or who your Dayan is. So let's just go through each of them. Copper IUD, it's over 99% effective. The copper IUD is a T-shaped device It's like the shape of a T. It's a small device and it sits inside the uterus. It gets placed by a provider. It's a painful insertion, but it just takes about 2-3 minutes to insert. It's an easy removal, but it sits inside the woman's body for 24 hours a day, 7 days a week. She does not have to be busy with it. And it could stay inside a woman's body for up to 10 years. So it's considered what's called a long-acting reversible contraception. That for somebody who wants long-term contraception, that is one of its benefits, that you don't have to be busy with it. You also can be spontaneous before relations. The person doesn't have to put something inside. It just sits there and it's there. The copper IUD has copper in there. So people who are sensitive to copper or who already have high copper levels in their body may not do well with it. People who have a bicornuate uterus, like a not typical shaped uterus, would not be a good candidate for it. Most people are a good candidate for a copper IUD, assuming that their uterus is a specific size and that they don't have an active infection. There are a couple of, pieces that the provider will ask, a couple of questions a provider will ask before placing it, but most people who want a copper IUD can totally get a copper IUD. Now, what is important to bear in mind is that some people report heavier, crampier periods when they have a copper IUD. So for someone who has that problem already, it may not be a great option for them. Some people report that when they got the copper IUD for a few months, their body had to adjust to it. So for those first few months, they had cramping and heavier periods or spotting between periods, but then their body adjusted beautifully to it and they didn't have to think about it and they just kept it in their body for as long as they needed it. It does not impact a person's cycle in the sense that it doesn't stop ovulation. It's not giving you synthetic hormone. The way it works is that the copper is a very strong spermicide. It kills sperm. So when it enters the uterus, it can't go and fertilize an egg. It also prevents an egg did get fertilized. It will prevent it from implanting in the uterus and becoming a pregnancy. So it has two mechanisms of action. I want to mention that it's also used what's called as emergency contraception, which means if somebody had had unprotected relations and they realize that they don't want to get pregnant, and one of the options available is to place a copper IUD within 5 days of having unprotected relations, because that will prevent pregnancy from happening. The copper IUD is covered by most insurances, and I will mention that less than 1 out of 100 women will get pregnant over the course of 12 months with a copper IUD in place. That's why it's one of the most effective forms of contraception. Are there people who have gotten pregnant on it? Yes. And if a person does get pregnant on it, one, they're at increased risk for having what's called an ectopic pregnancy, where the pregnancy does not implant in the uterus and the pregnancy goes off to the tubes or somewhere else. And that's a medical concern, potentially. A significant one, potentially. It's not likely to get pregnant on the copper IUD. And even then, many people who, if they even did get pregnant, will be fine. But there is an increased risk that if a person gets pregnant on it, that they can have an ectopic pregnancy. Now, some people who bleed heavily and spot on the copper IUD, they do well with taking certain supplements to offset it, or taking Advil to offset it. So it's not just like there's nothing to do, or they go and remove it. I recently removed the copper IUD for a woman. 2 of her sisters had babies with us, so we're already quite connected with the family. I removed her copper IUD, and what she reported was interesting, and this is not the first woman who's told me this, is that she did well with it for a bunch of months. Her body tolerated it really well, and then at a certain point, her body just rebelled against it. She started spotting and cramping and bleeding and couldn't get clean to go to the mikvah, and at that point, she had it removed. I just removed another copper IUD, and that mother showed up to have it removed. She had done really well with it. She was just removing it because she wanted to go and have a baby. A person's fertility returns right away when you remove a copper IUD, because it's not like they suppress their hormonal system. So as soon as you remove the IUD, if they ovulated that day, they could go and get pregnant. It's a foreign object living in your body 24 hours a day, 7 days a week, 365 days a year. A person has to be comfortable with that idea. Does it cause some inflammation in the uterus? Possibly, right? It's a foreign object. Um, does the body absorb the copper? Could be. And different people, I'm imagining it does, and that different people at different rates. And copper is a heavy metal. So do I look at it like it's eating an organic cucumber every day? Of course not. It may have risks beyond those that are officially listed. I do want to mention that this is anecdotal, but there are definitely women who report that they felt that they had breast tenderness from it and mood changes from it. And even though it doesn't use hormones, I question if it's their form of copper sensitivity manifesting in different ways. They do have another IUD on the market that's metal and non-hormonal, but you would have to buy it from a different country. I don't know that I don't think it's available yet in the United States to my most recent research. And those IUDs use other metals, like they reduce the amount of copper and instead use metals like nickel. They use metals like titanium so that people who have copper sensitivity can still use such a product. Okay, next hormonal form of contraception, and that's a diaphragm. Also, religiously controversial, it's going to depend on who you ask. And a diaphragm is a round device around this size. It's rubber. There are different types of diaphragms on the market. A woman puts it inside before each act of relations, and she leaves it inside for at least 6 hours afterward, but she takes it out less than 24 hours later. And a diaphragm is, if used perfectly, it's 94% effective, which means 6 out of 100 women will get pregnant over the course of a year. So somebody using the diaphragm has to have that risk tolerance of getting pregnant because it's not the most effective form of contraception on the market. It has to be used with spermicide in order to be 94% effective. It has to be fitted right if you're getting the kind that gets fitted, but not the Kaya diaphragm does not need to be fitted. It's one size fits most. In the United States, it does require a prescription. So it's not something you can just walk into a pharmacy and purchase for yourself. At least in New York. It could be there are other states that have put it on the market, but not that I know of. Spermicide is like a gel or a foam. It comes in different forms, but it's a substance that kills sperm, and it gets put on the edge of the diaphragm and inside the center of the diaphragm. And spermicide can be irritating to some people. A diaphragm, it doesn't just have benefits. It's not just, it has a benefit that it doesn't live inside a person's body 24/7. It has a benefit that it's not going inside the uterus. It just goes inside vaginally and it sits right on top of the cervix. And it physically blocks sperm from entering the cervix, entering the uterus, and impregnating the woman. So it's a physical barrier. That's the mechanism of action. And the spermicide kills sperm. So it's like a dual approach. There are different types of spermicide on the market with different active ingredients. So if somebody is sensitive to one type of spermicide, like the one you purchase over the counter at CVS, that's nanoxynol 9. That's the active ingredient. They may do very well on Phexxi, which is a newer kind of spermicide. They may do well, it doesn't have any nanoxynol 9. They may do very well with Contragel, which is a spermicide that's sold outside of the United States, but you could buy it online. And that's a more natural kind of spermicide. So just because you're sensitive to spermicide, it doesn't mean you couldn't use a diaphragm. It means you may just have to switch with which spermicide you're using the diaphragm with. I think that using it accurately is really important, and I'll tell you why. A diaphragm involves the woman putting it in and taking it out, right? A copper IUD just sits inside. You don't have to do anything. If somebody's putting it in, but it's getting dislodged, or it's falling out, or they're not leaving it in for 6 hours, or they're not putting enough spermicide or in the right places, then it's going to be 88% effective with typical use. So if we walk down the street and we just, took a walk in my neighborhood, I live in Far Rockaway, and we just counted all the people in the neighborhood who use a diaphragm. On average, 12 out of 100 women are going to get pregnant over the course of the year. It's only the people who use a diaphragm perfectly where the effective rate is not 88, it's 94%. And only 6 out of 100 will get pregnant. So that's important to use it accurately and to use it correctly each time. We have a lot of mothers who use a diaphragm because, I work with home birthers, so they tend to be, cautious with pharmaceutical use, cautious with using medications, cautious with using drugs. They're cautious with synthetic, hormones. Some use the copper IUD. We've placed that. Certainly, that's a choice that we have. I mean, I've also prescribed synthetic hormone as well. And depending if a person's breastfeeding, that will guide which synthetic hormone is better to take during breastfeeding. A person should not take during breastfeeding as quickly. But we have mothers who are cautious. They don't necessarily want synthetic hormone going, to all over their body and into their breast milk, or they don't want to, burden that. So a diaphragm is actually a pretty popular choice in our practice. And we haven't had any failures yet, but again, meaning we haven't had anybody come back and say they've gotten pregnant on it. But again, you have to have a very large sample of people using it in order to detect the failure rate, because most people are not going to get pregnant when they use a diaphragm correctly. A diaphragm can be an increased risk factor for getting a urinary tract infection. And a way to reduce that risk of getting a urinary tract infection is an infection, by the urethra, by the bladder, or higher up. And a way to reduce the likelihood of that, firstly, is to get fitted properly if you're using the one that requires fitting, that it shouldn't be too big and obstruct urine flow. The second way to prevent a UTI and reduce the risks of that is to urinate before having relations and to urinate after having relations. I want to mention that the diaphragm preferably should be put in within an hour of having relations for it to be most effective, the spermicide. So to some couples, that's like a break in spontaneity, that they have to stop what they're doing and the woman has to place it inside. So that would be like a disadvantage to it. I'm just trying to give a balanced discussion of risks and benefits and the effectiveness of each one so that people can choose what risk benefits work well for themselves and which ones they're comfortable accepting. Okay, after the diaphragm, I do want to mention that there's something called a cervical cap, and the cervical cap works very similarly to the diaphragm. It's just like smaller, and you have to know exactly where your cervix is to put the cervical cap directly on the cervix. That's why if you're choosing a physical barrier method, and the cervical cap requires spermicide, it doesn't save you from spermicide. If you're going to choose a physical barrier method, the diaphragm would be a better option. It requires knowing your anatomy a little less perfectly. And I mean, it's still good to feel that your cervix is blocked, and it is good to put your finger inside and feel, do you feel the tip of your nose behind the diaphragm? Do you feel your cervix, right? We said the cervix feels like the tip of the nose. Do you feel your cervix blocked by the diaphragm? Because if the diaphragm isn't blocking your cervix, you don't have protection, right? That's how the diaphragm works. And I want to quote verbatim, and this is from Varney's, which is a gold standard textbook within the midwifery community. And they've put out a newer version of this textbook, and this is not their newest version of their textbook. It's the one before that. So it could be they've updated it, but I don't know that they've done that. And I want to mention what the exact difference is between a cervical cap if they don't mention it here. Okay, yeah, a cervical cap tends to be less effective, especially for some than a diaphragm, especially for somebody who's previously had babies. So just so you know that. Okay, another non-hormonal form of contraception, and this is so incredibly religiously controversial, like I would recommend this to somebody not Jewish, but I'm just going to still mention it, is a condom, because it's 98% effective, a male condom that the man, covers his organ, his penis, with a piece of synthetic. It doesn't have to be synthetic, but he covers himself with something that's a physical barrier, and it does not require any spermicide. I do know if people have gotten a heter for that, but that's not common, just so you should know that. And that's incredibly religiously controversial. Another form of contraception that I don't know of anybody Jewish ever using but it exists. So if you ever read about it, you can know what it is. It's called withdrawal. And withdrawal is when a man does not ejaculate, does not release his semen inside the woman's vagina. It's that he pulls his organ out and he releases outside. But I've never heard of anybody being told that that's permissible. I've never encountered that. Okay, another form of non-hormonal contraception is something called the sponge. And the sponge is exactly what it sounds like, by the way. It looks like this. Like the product I've seen is about this size. It's spongy. When you wet it, it like foams up, and it's basically spermicide and a physical barrier because it's a sponge. And for women, though, who've given birth before, with perfect use, there's a 20% failure rate. For women who have never given birth before vaginally, then with perfect use, there's a 9% failure rate. So for a person who's never had a baby, then the sponge it doesn't have such a bad failure rate compared to, let's say, the diaphragm. It's 9%. But for someone who's given birth before, 20% is a pretty high failure rate. That means 1 in 5 women are going to get pregnant on it over the course of a year. The sponge does not require any prescription. You can go and buy that completely on your own. So just so you know that there's no barrier to accessing it. Spermicide, right? How many people are walking around with children that they've conceived on spermicide? A lot of people, and I'll tell you why. Because spermicide, which is that chemical, it's like a gel or a foam or a film. It comes in different forms, but spermicide has different ingredients in there that kill sperm. And the spermicides that you buy in CVS typically use nonoxynol 9 as like the main ingredient. And not all spermicides actually kill the sperm. Some of the less irritating spermicides, they actually change the pH of the vagina. They actually change, they more affect the woman's body as opposed to the sperm that's been ejaculated from the man's body. And maybe that's why they're less irritating. But in any regard, spermicide is 18% failure, has an 18% failure rate with perfect use. And with typical use, it has a 28% failure rate. So that's pretty high for somebody who's very serious about not having a baby. If someone has a medical reason to not have a baby, we would not recommend spermicide. It just doesn't afford the person the adequate level of protection if a person truly needs protection. If you use no method, 80, and you just have unprotected relations, the typical 85 out of 100 people will typically get pregnant over the course of 12 months. So it's, I guess you could call it 15% effective, just having unprotected relations. You have a 15% chance of not getting pregnant over the course of a year. Now, a very natural approach, and you know, I by professional orientation, I'm a naturalist, so I'm coming with that bias and I'm coming with that perspective, and it doesn't mean it's the right perspective for everybody, and I completely appreciate that. But and like I said, I prescribe synthetic hormone with truly giving women the full consent, like fully informed decision making, where they truly knew the risks of what they were putting in their body, and I completely honor the choice for people to make that choice. And I'm sure they asked a postake, and I always mention to people to discuss it. I don't want to take any religious responsibilities like I've described. So there's a really terrific method, and it's called the fertility awareness-based method. And that means a woman becoming exquisitely in tuned to her body to know when her opportunity each month is to get pregnant. And women are not capable of getting pregnant on any given day of the month. A woman has to gets pregnant if she's ovulating. So which means if her body released an egg that's available for fertilization. So there's a narrow window of time each cycle that a woman potentially has to get pregnant. Some people have periods and they don't ovulate, by the way. Just because a person has a period each month, it doesn't for sure mean that they're ovulating. It doesn't for sure mean that they have that opportunity to get pregnant. But assuming a healthy, normal cycle, we're going to assume that the person's ovulating. But all those other days of the month, they can have, if they're not having relations like a few days before ovulation, because you cannot You can get pregnant if you have unprotected relations a few days before ovulation, because the man's sperm can live in a woman's body for up to 5 days. So even if in that moment when they were intimate, they could not conceive a child, if 2 days later that woman ovulates and then the egg is available for fertilization, that sperm that was deposited in her body 48 hours earlier can go and impregnate her. So, but if a person identifies ovulation in their cycle, they can potentially abstain from having relations for the days leading, those 5 days leading up to ovulation, during ovulation, and shortly after ovulation. And then the rest of the month, they can have unprotected relations and completely not get pregnant. So some people like to learn their body's signs of ovulation. And there are a number of signs of ovulation. The mucus will look like egg whites. Somebody who's taking her body temperature before she gets out of bed in the morning, her basal body temperature, and is tracking her body temperature, will notice a change in body temperature at ovulation and will be able to say, oh, I've ovulated, and know that shortly afterward. Somebody just put in a message that I want to address, but I'm just going to finish this thought and then we'll address questions. But if a woman, after she's ovulated, knows she's past ovulation, for the rest of the month, she can go and have relations and doesn't need contraception, right? So taking body temperature, mucus, using LH surge tests, they sell those over the counter, where a woman uses a urine test. It looks like similar to a pregnancy test, the urine pregnancy test. And those LH surge tests, they measure the woman's LH hormone in her body. And then when they start seeing that there's an increase, they notice that there's an increase, and that increase in hormone happens shortly before ovulation. So that's able to help pinpoint ovulation. A fourth way that people can learn when they're taking when they're ovulating is to feel their cervical position. The cervix will feel a little different during ovulation. So if someone checks themselves every day and really learns what their cervix feels like, they'll notice there's a softness and a change in position to the cervix, not just different mucus coming out. A person may detect that they feel differently, that they have an increase in sexual desire, an increase in libido around ovulation. A person may have some cramping on one side during ovulation. I've oversimplified these methods, and each of them we could have a thorough discussion just in learning the signs and symptoms of ovulation for over an hour. So I want to mention that if somebody wants to use these methods, I would recommend a book called Take Charge of Your Fertility. And I'd also recommend really making sure that you know the method, because if you're relying on it in either direction, either to get pregnant or to not get pregnant, you want to know how to do it. Like, for example, taking basal body temperature, somebody who's up a lot at night, whether it's because they're up with a baby or they get up frequently to urinate or they work as an on-call midwife, right? Somebody who's up frequently at night, their basal body temperature may be influenced by that. It may not be reliable for them. So that's what I mean to say, that if you're going to use the method, we did not delve into it well enough to just, I'm just giving like the overview on it. Now, one of the benefits of using the fertility awareness method is that people become in tune to their body. They don't have to use any foreign object, any foreign device. It's very natural. They just abstain from relations during that period of time, those number of days leading up to ovulation, during ovulation, and right after ovulation. However, I want to mention that for a religious person, that time sometimes coincides with mikvah night, depending on how long a woman's cycle is. Is it a 40-day cycle, a 28-day cycle? And the other piece I want to mention is that also for religious people, if they have a limited number of days that they're mutter each month, that they're permissible to have relations, they don't necessarily want to give that away toward their form of contraception. I will mention that for a woman who's breastfeeding, I have questions about it that I don't have answers to. And I wish I had answers for them. Like, do the hormones of breastfeeding and the shift in the body during breastfeeding, which is individual for each person, how much prolactin, how much breastfeeding hormone they have, how much estrogen they have, how much progesterone, it's very different for each person. But can they mimic signs of ovulation sometimes and disrupt the typical signals that a person could usually rely on? Can breastfeeding get in the way of that? That's a real question. Can breastfeeding be used as a form of contraception? Let's delve into that for a minute. And obviously, that's not relevant to somebody who doesn't have a baby or somebody who's not breastfeeding. And there are people using contraception who don't have a baby or who aren't breastfeeding. But for those people who just had a baby and are breastfeeding, contraception is considered lactational amenorrhea for contraception, like relying on breastfeeding to suppress your ovulation, or nursing clean, as people call it, is 98% effective. That's very high, but they give that statistic for the first 6 months of breastfeeding, and a person has to have not given the baby any pacifier, any bottle, even pumping into a bottle means you break out of that 98% effective. And the baby has to be sucking directly from its mother's breast, no artificial nipple, and the baby has to breastfeed every 2 to 3 hours, like around the clock, literally. So if your baby gives you a 4-hour stretch at night, it could be you still won't ovulate, but it could be you will. And then we don't have statistics to share with you what likelihood you are to ovulate or not. So it's not common that people can feel reassured that for those 6 months, it's 98% effective. Many babies will give their mothers a stretch at night, way before the 6-month mark. I want to mention with breastfeeding, a person may have the opportunity to get pregnant and ovulate before they have their first period. So people who say, I'm going to wait till my periods start coming when they're breastfeeding, they can get pregnant possibly before their first period kicks in. We've had mothers show up to our practice saying, I just don't know my dates because I was breastfeeding. I never got a period and I got pregnant. I don't know if I am 2 months pregnant or 4 months pregnant or 5 months pregnant, right? If you're going to use breastfeeding as a form of contraception, and we have mothers who do that all the time, they say, this is my 4th child. I've seen my body do it all the time. I nurse clean for a year. I feel comfortable taking that risk. Worst comes to worst, I look at it like this was God's, God's way of sending me a baby. We've had mothers tell us all different things. I will mention that if you're going to do that, then at some point, if you suspect pregnancy or at certain intervals, take pregnancy tests so that you don't run into a situation where you're 4 or 5 months pregnant or 3 months pregnant and have absolutely no idea whether or not when you conceive that baby. Like at the point that you think you might start ovulating, to pay attention, to take pregnancy tests, unless you're somebody who's comfortable going for a dating ultrasound and won't have an issue with just going for a sonogram to assess how far along their pregnancy is. But if you're not going to want that sonogram, then a beneficial thing to do is to take pregnancy tests using the same company test, first morning urine, so that the testing is done in a consistent fashion, and to document, like if you took a negative test, I've helped people pinpoint their estimated due date when they were able to tell me when they took a negative test, when they took a positive test, when that positive test had a very light line, when their positive test had a darker line, using the same company test. So it can really give you valuable information that you don't just have to run off for an ultrasound. I'm just going to look at the notes very quickly so that I make sure I'm not missing anything, because this conversation is so incredibly important. I think that's really the menu of options. Okay, somebody's asking me, can you please talk about the risk associated with a Kala using hormonal form of contraception to get cycle control in advance of her wedding? That's $1 million question. And, there are many, many books published on what hormonal contraception does to a woman's body. The documentary, The Business of Being Born, which is like the expose that showed people what the American industrialized birth system looks like in a hospital, comparing it to a home birth setting with less intervention. The filmmakers, they've created another documentary about the business of the contraception pill. And I would I have not watched it. I tried to get access to it and have not been able to, but that would just, I'm recommending it just because they're excellent filmmakers, but that could just be a starting place. But I've not personally watched that documentary. I've read books on what hormonal contraception has done to people, and there's way more research out there than what I've read. It's a very involved discussion, especially for a person who is going to cherish their fertility and want their fertility back immediately. And um, most people will get their fertility back right away, but that is not a foolproof guarantee. And what else the hormonal contraception does to people's moods, how they connect to their partner, relationship. It's a very involved discussion and way beyond the scope of this conversation, even though it's an incredibly important discussion. And I'm not callous toward people who want to not have a chuppah smida, and I know that not everybody has regular cycles, that they can just schedule their calendar that they can just schedule their wedding date around their calendar. Some people are gifted with that they have very regular cycles. Is there what to do to help regulate a person's cycles naturally? Absolutely. It doesn't have to be through a birth control pill, but also way beyond the scope of this discussion. I'm trying to think, should I share this? I want to share a little bit about my background. I, I was born to a mother, as I mentioned, who birthed me unmedicated and did not take any drugs to have me. And that was a very conscious choice. When my mother birthed me, it was 30 something years ago, and she did it with Lamaze. And in today's day, my mother would definitely be a home birther. It was like the equivalent, birthing with Lamaze then is like in today's day being a home birther. And I'm coming from a background very much so that with caution toward Western medicine. And I don't think my mother has given me antibiotics, thank God, ever in my life. I don't think my mother's ever given me a prescription medication ever in my life. I don't think I've ever needed it, thank God. And my mother has exclusively breastfed me. So I like to always frame this discussion by saying that my professional orientation as a midwife doctor is also influenced by who I am as a human being, right? And as much as I give people recommendations, I'm coming from a naturalist perspective and from a non-interventionist perspective. And I like people to know that, because there are other perspectives out there, and those perspectives can be just as equally valid, if not more valid. And people have the right to know that this discussion was very much framed from the perspective of somebody seeking natural kind of care, more natural kind of care, meaning our contraceptive discussion. Our earlier discussion about pap smears and pelvic exams and breast exams, those are straight from mainstream medical guidelines. So also, I tend to favor that less is more. And I want to say that I tend to favor, as professionally, that if there's no true, real documented benefit, then don't do it. If it poses risks, take those risks seriously. If it has not shown to improve clinical outcomes, then think twice before consenting, right? So I'm coming from that perspective, that sometimes less is more, and mainstream medical guidelines have definitely moved in that direction when it comes to being checked. And so I think we've really wrapped it up. I wish we could open up the discussion for the forum for questions. I just I don't either want to bite off something that's way more involved and complex than what we can adequately answer. Michal, keep up your incredible activism. In any which way that I can be supportive, please let me know. I'm truly humbled to be part of this group, and I cherish our friendship. And to each of you who joined us tonight, I'm hoping that in some way this has opened up your mind, your heart, your way of thinking, and that in some way it can prevent you from and protect you from unnecessary checking, unnecessary screening that won't benefit you. And I'm hoping, or if it can just protect you from feeling capable to now go and research and go online and read recommendations and ask questions at your provider, choose a worthy provider, and to get care that really supports human dignity, to get care that's empowering, to get care that is consensual, to get care that in every which way involves the mother every step of the way. BRCA gene, quick question. When it comes to a BRCA gene, that's also a very nuanced and very complex discussion, because There are different BRCA gene mutations. I do want to mention that there are people who will show up having had genetic testing that was never recommended that they should have in the first place. And that the decision to test, it's not just, well, insurance is going to cover it and this person is recommending it, or it makes me feel safer. It's a decision. Think it through. If it makes you feel safer, there's validity to it. But what I mean to say is that once you have test results, it's like, what do you do now with that information? You always want to ask yourself, do you want to get those test results? Is it really warranted? Is it really beneficial? Is it really recommended? If somebody tells you it's recommended that you should go for testing, you can ask them straight out, can I see the guideline that recommends it? When somebody is recommending something, when a provider is recommending something that's evidence-based and supported by mainstream guidelines, they should literally be able to print it out that you are an eligible candidate for testing and be able to hand it to you in most situations. So if you don't feel confident that it's really recommended that you test, think it through carefully. A colleague of mine, he's a physician, totally different perspective than I have, but we happen to be friends. He has told me, he's a maternal fetal medicine specialist, which means he's an obstetrician, a gynecologist, a physician who has advanced training so that other obstetricians and midwives refer to him. He has told me he spends most of his day interpreting test results that should not have ever been taken in the first place, which means people who are undergoing testing that by mainstream medical guidelines, they never should have been tested for. And now they're left with this information. So what do you do with it? And we've had clients who came to this practice with charts that were like, okay, now we know that they have this, but 1 minute, why was this fished for in the first place? There was no clinical indication to test. Sometimes there are clinical indications to test, but if you don't have the criteria to truly get tested, it's not like more is more. Sometimes less is more. So I want to just mention that before running to get tested for BRCA, think it through. If you should get tested, then that's a different discussion. But if you shouldn't, think that, get a second opinion. Should you even test? Even that is worthy of a second opinion. And again, you can always ask for where is the recommendation in print. You have the right to that. Yeah. Okay. Lots of love to everybody. And it was deeply humbling and a very big privilege.
Judy, thank you so, so much. We're so lucky to have you. And thank you for all your wisdom and your incredible help.